Welcome. In this session, we'll be discussing about microinvasive glaucoma surgical procedures or MIGS in short. They are also known as microincisional or minimally invasive glaucoma surgeries. We'll also discuss about non-penetrating glaucoma surgeries or NPGS, but NPGS procedures have become less popular presently with the advent of MIGS. Characteristics of MIGS procedures, particularly in comparison with trabeculotomy and plate-based tube shunt surgeries, include high safety profile with a low complication rate, minimal disruption of normal anatomy of the eye, particularly the angle, moderate efficacy to lower intraocular pressure with a reduced ability to obtain intraocular pressure less than 15 millimeters of mercury reliably without additional anti-glaucoma medications, and a failure to lower intraocular pressure in an eye in which the preoperative intraocular pressure is already low, and this is important to remember. So MIGS procedures are not effective in lowering intraocular pressure in patients who have a low intraocular pressure preoperatively to start with, being easier for the patient and the surgeon with rapid recovery for the patient, and being able to be easily combined with a phacoemulsification procedure. Most MIGS are ab interno procedures in which the angle is approached from within the eye, and with a temporal approach nasal quadrant of the angle is selected for the procedure because of easier access as well as because of a wider Schlemm's canal in this region. And for MIGS procedures involving implantation of a device into the Schlemm's canal, entry of the device into the Schlemm's canal can be confirmed by reflux of blood into the anterior chamber, which may be promoted by mild lowering of intraocular pressure, and following the implantation of the device, this blood reflux can be stopped by pressurizing the anterior chamber. Most MIGS implants are available in preloaded injectors, and the greater the extent of the angle treated, the more is the potential for intraocular pressure lowering. And this is particularly valid for procedures involving TM disruption which do not involve implantation of a device. And this is so because aqueous flow in Schlemm's canal is not continuous circumferentially, as the Schlemm's canal is septated and discontinuous. As a result, greater the extent of treatment, more is the amount of aqueous outflow which can occur through the treated area of the angle. Potential disadvantages of procedures involving device implantation include foreign body reaction and consequent fibrosis, the implant acting as a nidus for infection, and the stents or the implants can get blocked, or they can block the lumen of adjacent pathways. This is a photograph of an iStent, one of the most commonly employed MIGS devices, and in this photograph we see such an implant placed on a fingertip for size comparison. And most studies suggest IOP lowering efficacy in decreasing order as follows. MIGS alone has a higher IOP lowering efficacy as compared to MIGS combined with phacoemulsification, which in turn has a higher IOP lowering efficacy as compared to phacoemulsification alone. MIGS procedures are usually considered in patients with mild to moderate glaucoma as an alternative to lifelong anti-glaucoma medications with their attendant cost, compliance and tolerance issues. As an alternative to trabeculotomy and tube shunt surgery in patients with poor conjunctival status, risk of postoperative hypotony, and risk of choroidal effusion or hemorrhage intraoperatively or postoperatively. And most MIGS procedures require clear cornea and wide palpebral fissure for gonioscopic visualization of the angle. Following MIGS procedures, steroids and antibiotics are administered, and pilocarpine needs to be administered for procedures involving trabecular meshwork disruption. Following these procedures, pilocarpine avoids closure of the entry made into the Schlemm's canal and formation of peripheral anterior synechia by pulling the scleral spur and the iris posteriorly. Complications following MIGS procedures include transient increase in intraocular pressure, which occurs in up to 10% of patients undergoing these procedures, hyphema, which is very common, blockage of the implant, malposition or displacement of the implant, iridodylisis, cyclodialysis, infection and hypotony, along with shallowing of anterior chamber and choroidal effusions, which occur with devices draining aqueous from the anterior chamber into the subconjunctival or suprachoroidal space. So we classify the MIGS procedures as angle MIGS procedures, which drain aqueous from the anterior chamber to the Schlemm's canal, subconjunctival shunts, which drain aqueous from the anterior chamber to the subconjunctival space, and suprachoroidal shunts, which drain aqueous from the anterior chamber to the suprachoroidal space. Among the angle MIGS procedures, we have trabecular meshwork bypass stents, laser procedures, and trabecular meshwork disruption procedures. iStent, available from Glaucoma Corporation, is made of titanium and is inserted through the trabecular meshwork into the Schlemm's canal ab interno and under gonioscopic visualization. So in this figure we see a second generation iStent implant with its head in the Schlemm's canal and its flange within the anterior chamber. So the iStent provides a wider entry for aqueous in the anterior chamber into the Schlemm's canal as compared to the ports in the inner wall of the Schlemm's canal. And two stents can be positioned simultaneously 2 clock hours apart and is said to provide a better IOP control. So we have two generations of iStent, iStent G1 and iStent G2, with the iStent G2 also known as iStent Inject. So this figure shows an iStent G1 device and its tip pierces the trabecular meshwork tangentially with the rings on the outer surface of its body holding the device in its place within the Schlemm's canal and the snorkel opening into the anterior chamber. This diagram shows an iStent G2 or an iStent Inject device, and after its tip penetrates the trabecular meshwork radially, the head remains in the Schlemm's canal, the thorax remains at the level of the trabecular meshwork, and the flange remains in the anterior chamber. And the iStent G2 comes as two shunts within one package. So this figure shows a gonioscopic view of an iStent implant. IOP lowering efficacy of iStent has been reported to be between 20% and 30%, and it has been found that 2 or 3 iStent G1 or 2 iStent G2 can achieve an IOP of 15 mm of mercury or less in 80 to 90% of patients in the first 1 to 1.5 years following implantation. Hydrus from Alcon is also a trabecular meshwork bypass device and is also known as a Schlemm's canal scaffold. It is a flexible device consisting of two parts: a longer segment which remains inside the Schlemm's canal, dilating 3 clock hours of the Schlemm's canal up to 4 times, thus increasing the access of aqueous into the collector channels on the outer wall of the Schlemm's canal, and a shorter segment called the snorkel which remains within the anterior chamber, draining aqueous from the anterior chamber into the Schlemm's canal. The Hydrus is also introduced into the Schlemm's canal through the trabecular meshwork ab interno and under gonioscopic visualization. So this is a gonioscopic image of an eye which has underwent implantation of the Hydrus device, and we see the snorkel within the anterior chamber and a hazy view of the intra-Schlemm's canal segment. And the IOP lowering efficacy of Hydrus has been reported to be 15% when combined with phaco. Laser-assisted endoscopic trabeculotomy is another angle MIGS procedure in which 300 to 500 micron perforations are made in the trabecular meshwork with a laser by introducing an endoscope ab interno and under gonioscopic visualization. Thus it avoids using a stent and its associated complications. This procedure should be differentiated from laser trabeculoplasty, in which perforations are not created. Ab interno trabeculectomy or trabecular meshwork disruption procedure is another angle MIGS procedure in which the inner wall of the Schlemm's canal and the trabecular meshwork are removed ab interno and under gonioscopic visualization, and we have two available devices, the Trabectome and the Kahook dual blade. The Trabectome, as shown here in this photograph, is available from Neomedics, and it causes plasma mediated ablation with a bipolar electrode, and up to 180 degrees of the angle can be treated by introducing the handpiece through one paracentesis. And as we have discussed, the greater the extent of treatment, the higher is the potential for intraocular pressure lowering. Like laser trabeculotomy, Trabectome and Kahook dual blade avoids using a stent and its associated complications. These procedures are different from goniotomy in that in goniotomy only an incision is made in the trabecular meshwork, whereas in these procedures the trabecular meshwork including its lips gets ablated or removed. By the lips of the trabecular meshwork we mean the anterior and the posterior margins of the trabecular meshwork. And when these lips are not ablated, these lips can reocclude the Schlemm's canal in adult eyes, and this is why goniotomy, which does not ablate the lips of the trabecular meshwork, does not work in adult glaucoma patients. The Trabectome and the Kahook dual blade are effective in both adult and pediatric glaucoma patients because they remove the lips of the trabecular meshwork. The Trabectome and the Kahook dual blade may also have an irrigation aspiration feature to clear debris and maintain anterior chamber and to dissipate heat in case of the Trabectome. For the Trabectome technique, viscoelastics are not used as gas bubbles may be generated during the procedure which may get trapped in the viscoelastic, impairing visualization of the angle. The tip and the footplate of the Trabectome perforates the trabecular meshwork and enters the Schlemm's canal as shown here in this figure, and then the trabecular meshwork is ablated from its Schlemm's canal aspect. And ablation is confirmed by the visualization of the outer wall of the Schlemm's canal in the area where the trabecular meshwork is ablated. Ablation of 90 degrees of trabecular meshwork is attempted on either side of the initial entry point in the trabecular meshwork, and this is done by sliding the tip and the footplate of the trabectome circumferentially within the Schlemm's canal. And as we have discussed, pilocarpine is administered for a few months post-operatively to prevent reocclusion of Schlemm's canal and formation of peripheral anterior synechia. In the Kahook dual blade or KDB from New World Medical, there are two blades which incise the anterior and the posterior margins of the trabecular meshwork, thus excising a strip of trabecular meshwork. The sharp tip of the instrument is used to enter the Schlemm's canal through the trabecular meshwork, and the ramp is used to glide the instrument in the Schlemm's canal, and the instrument is then swiped circumferentially through 3 to 5 clock hours of the Schlemm's canal. As we have mentioned, the two blades excise a strip of trabecular meshwork by creating two incisions at the anterior and the posterior edge of the trabecular meshwork. And the advantages of the Kahook dual blade in comparison with the trabectome are a more complete removal of the lips of the excised trabecular meshwork and no thermal damage. Here we need to note that the GATT procedure which we have described in the previous session is not considered as an MIGS procedure. Among the subconjunctival shunts we have Zen, the Express shunt and the InnFocus shunt. The Zen gel implant is available from Allergan and it's a 6 mm flexible tube made of porcine gelatin and is implanted ab interno under gonioscopic visualization, draining aqueous from the anterior chamber directly into the subconjunctival space. It comes in 3 bore diameters, with the smallest bore being easiest to insert but with highest resistance to aqueous flow. In contrast to plate-based tube shunts, the Zen gel implant is much smaller, thus avoiding erosion through the conjunctiva and corneal endothelial damage. The Zen gel implant is inserted with its injector, which penetrates the angle and exits the sclera into the subconjunctival space approximately 3 mm behind the limbus. And mitomycin C can be used as an adjuvant, but it should be applied in the subconjunctival space before the Zen gel implant is introduced. And complications from Zen gel implant include, in addition to blockage of the shunt, bleb-related issues as with trabeculectomy, because this implant drains aqueous into the subconjunctival space, creating a bleb. And these bleb-related issues can be transient hypotony associated with shallow anterior chamber and choroidal effusion and infections. Two other devices which drain aqueous from the anterior chamber to the subconjunctival space are the Express shunt from Alcon and the InnFocus or the pressure flow microshunt from InnFocus, but both of them are implanted ab externo, that is from the scleral aspect of the angle, And we have discussed the express shunt in the session on trabeculotomy, and this is a photograph of the pressure flow microshunt. Then we have the suprachoroidal drainage devices, which attempts to increase aqueous outflow through the uveoscleral route by draining aqueous humor from the anterior chamber to the suprachoroidal space, thus sparing both the conjunctiva and the trabecular meshwork. And from the suprachoroidal space, the aqueous further drains either into the choroidal vasculature or through the conjunctiva via intrascleral channels. The Cypass microstent or CMS was available from Transcend Medical and was implanted ab interno under gonioscopic visualization. And here we see a photograph of the Cypass microstent. And in the technique, a guide wire with the CMS inside is passed posterior to the scleral spur, creating a localized cyclodialysis cleft by disinserting the ciliary body from the scleral spur till the suprachoroidal space is reached, and the guide wire is then retracted. And with this device also, there is a risk of transient hypotony along with blockage or migration of the device. And because of endothelial cell loss, it is no longer available from the manufacturer. The iStent G3 is a suprachoroidal shunt available from Glaucoma but is not yet FDA approved. And another suprachoroidal shunt is the Solex Gold Micro Shunt or GMS from Solex. Non-penetrating glaucoma surgery or NPGS are not considered as MIGS procedures and have become less popular with the advent of MIGS. They do not penetrate the anterior chamber, and this is important to remember. In comparison to trabeculectomy and plate-based tube shunt surgeries, they are less effective in reducing intraocular pressure but with a reduced rate of complications. They are technically challenging and they may need to be converted to trabeculectomy intraoperatively. They do not spare the conjunctiva for future filtration procedures and are indicated for open-angle glaucomas only. Non-penetrating procedures include three surgical techniques: deep sclerectomy, viscocanaostomy, and canaloplasty. In deep sclerectomy, underneath a conjunctival flap, a partial thickness scleral flap is created as in trabeculectomy, and a block of corneoscleral tissue is removed, leaving behind a thin layer of Descemet's membrane and sclera, and aqueous flow is said to occur through this intact Descemet's membrane. Viscocanaostomy procedure is deep sclerectomy plus injection of viscoelastic into the Schlemm's canal to dilate the Schlemm's canal. And canaloplasty procedure is deep sclerectomy plus 360 degrees dilation of the Schlemm's canal by injection of viscoelastic with an illuminated microcatheter, followed by placement of a suture in the Schlemm's canal and tying the ends of this suture under moderate tension to stretch the Schlemm's canal. Microinvasive glaucoma surgery or MIGS, as compared to trabeculectomy and plate-based tube shunts, have a lower rate of complications but with a lower efficacy in reducing intraocular pressure. Most MIGS are ab interno procedures performed under gonioscopic visualization. MIGS are a treatment option for mild to moderate open-angle glaucoma. MIGS procedures improving drainage of aqueous from the anterior chamber to the Schlemm's canal include trabecular microbypass shunts such as the iStent and the Hydrus, laser endoscopic trabeculotomy, and the trabecular meshwork disruption procedures such as with the Trabectome and the Kahook dual blade. MIGS procedures which drain aqueous from the anterior chamber to the subconjunctival space include the Zen gel implant, the express shunt, and the pressure flow shunt devices. MIGS procedures which drain aqueous from the anterior chamber to the suprachoroidal space include the Cypass microstent, the Solex Gold microshunt, and the iStent G3 devices. Non-penetrating glaucoma procedures which are not considered as MIGS do not enter the anterior chamber. They include deep sclerectomy, viscocanaostomy, and canaloplasty procedures. Thank you for listening.